Let me share with you the issues of PA pressure assessment. Now, if you see a TR and you report a TR velocity is this much, and based on that, if you tell that PA pressure is 55, 60, 65, a very high probability, more than 50% chance is that you are going to be wrong. So why so? That's what the whole talk is about. But I tell you right in the beginning, it's maybe a good idea to subscribe, because I'm going to keep on posting newer and newer ideas and concepts through the YouTube channel, and to get connected with you guys. And if you are subscribing, you would be notified the moment I put a video, a new concept, new discussion, and you can see that. Let us see how we calculate the PA pressure based on tricuspid regurgitation. That's the commonest thing you do day in day out in your clinical echo. Now, how do we calculate PA pressure from TR? We know that RV pressure is equal to PA pressure in systole, because there is no pulmonary stenosis. So now what do we need to know? If we know the RV pressure, we would say, okay, this is PA pressure. Agreed? Now the RV pressure, how do we know the RV pressure? RV pressure is that if we find a RA pressure, done, and if we find difference between RA and RV pressure, and we add up these two, we would get an RV pressure. So gradient or a difference between RA and RV plus the RA pressure in systole would give me RV pressure, and if I get an RV pressure, I would get. So RA pressure, I tell you, we have some rough formulas of doing it, and the gradient between RA and RV is calculated by tricuspid regurgitation, and we know a modified Gorlin formula that if we multiply the square of a velocity with 4 and we get a gradient. So RV systolic pressure is 4V square, that is the TR peak velocity on a CW Doppler, and the RA systolic pressure, which is based on the IVC. I would tell you that. So similarly, you can calculate the PA diastolic and hence the PA mean pressure also. Now PA diastolic pressure you can calculate based on the pulmonary regurgitation. So now here we know the RV diastolic pressure, okay, in diastole, as this valve, this tricuspid valve is open, is as good as an RA pressure. So RV pressure is equivalent to RA pressure in diastole. Now if I know the RV pressure in diastole, I would know the RV pressure in pulmonary artery. So PA pressure diastolic is equivalent to what is the gradient between the pulmonary artery and RV in diastole. So what is different between their pressures? And if we add RV diastolic pressure, which is equivalent to RA diastolic pressure, we can say this is pulmonary regurgitation, and the formula is same Gorlin formula to calculate the gradient between the two chambers, and the way is 4V square of the pulmonary regurgitation, whether it's peak pulmonary regurgitation or end diastolic pulmonary regurgitation. So PA diastolic pressure is 4V square of the pulmonary and an RA pressure diastole. So this is how we calculate PA pressure systolic and PA diastolic pressure, and you guys know that these pressures can be calculated, and PA systolic can be calculated by the peak TR velocity. PA mean can be calculated by TR mean velocity plus the RA, and or if you do a PR peak velocity, okay, and then this would be a mean pressure of the right of pulmonary artery. Pulmonary artery and diastolic pressure can be calculated by the diastolic velocity at the end diastole of the pulmonary regurgitation. Let's take a couple of examples of calculating the PA pressure. That's a patient where it's about moderate pulmonary regurgitation, and you see, tricuspid regurgitation. You see, this is the TR jet envelope, and RA pressure was 15 based on IVC dilated and non-collapsing. I would show you that in subsequent slides. And how now from let us discuss about calculating. Now let's say what is the velocity. Velocity is about 4 meter per second, and if you multiply velocity square, okay, the velocity was 5.3 here, 5.3, so 5.3 square multiplied by 4, that is 28 multiplied by 4, and you add RA pressure to it, it would give you a pressure of pulmonary systolic pressure in the artery, so that is 128. So this is how you calculate. Let me give you an example of calculating diastolic pressure. So if you want to calculate the mean pressure in the pulmonary artery, you take the peak pulmonary regurgitation velocity. If you want to know the end diastolic pulmonary pressure or diastolic PA pressure, you take end diastolic PA velocity. How do we do it? PA end diastolic pressure is, now you have the PR gradient 4V square. Let us say the PR velocity here was about 2 end diastolic, and you take a velocity of 2, you square it, and you add 3, as the RA pressure was 3, there was IVC which was collapsing and it was not dilated. So PA end diastolic pressure of 19. So you now have understood how to calculate PA systolic and diastolic pressures. This makes all of us very happy, and this had been teaching for last about couple of decades, in fact, not years. Okay, so whenever there is some new technology, and that's what happens, we are so enthusiastic and happy about it, and then we do a reality check, we do studies comparative, and then we are sobered by those studies, and then we realize no, we need to improve on technique before we reach realistic figures. So now the reality is different. Let me take you step by step here. The problems are with the startup, and initial enthusiasm came from couple of studies which were done in fact on a normal PA pressure patients, and PA pressure was mildly elevated. They did not take patients with congenital heart disease, valvular heart disease, and patients with severe tricuspid regurgitation and severe pulmonary artery pressure elevation. So that was a very major limitation in clinical practice. We are not going to measure PA pressure in a normal individual. We want to know it in a patient where there is PA pressure which is very high. So these were the studies, and that gave a lot of enthusiasm to us, and this enthusiasm was immediately blunted by our intervention and seeing the PA pressure correlation with the invasive PA pressure by catheterization. And we noted this is the study where about 65 patients were taken, and that study was about 2009, and they showed that the Doppler echocardiography was accurate only in less than 50% of the patients, more than 50%, and about 48% we were inaccurate in assessment. We went 10 millimeter above or below both overestimation and underestimation as compared to the catheterization. Not one, plenty of studies, right? Now we have plenty of studies which are stating that you can have a variability between cath data and echo data as far the PA pressures are concerned, and you look at Faber, which has given a very excellent result which shows that we are inaccurate in calculating PA pressure based on echocardiography as compared to the catheterization. 57% patients we are wrong, right? So then look at the scatter of variation between, that's the difference between the systolic pressure calculated by echo and cath, and these are the differences. The differences can go as high as 50 millimeter of mercury on either side. That is huge. So now where did the error happen? The very first error happens, let's say what were the ingredients of our recipe of TR or for PA pressure calculation. Our recipe included RA pressure, our recipe included the TR peak velocity. Okay, so there's something wrong there. Now RA pressure. So where we went wrong? Let's first see how do we calculate RA pressure. We calculate RA pressure from a proper subcostal view. We take it in a longitudinal section and we take an end expiration diameter about a centimeter or 2 centimeter from its insertion into the right atrium, and that should be just proximal to the hepatic veins. The hepatic veins are here, they should be ahead of that, and we should take an inside edge to inside edge measurement, and it should be perpendicular to the wall, and preferably we would like to do it with an M mode because that would give you a very crystal clear diameter because of the high resolution of an M mode echocardiography. And then we see one is we take a diameter, that is 1, to see whether it's dilated or a normal size. 2 is that whether it's collapsible or not. If the pressures are high, it would not be collapsible. So collapsibility is seen by 2 methods. By a sniff, a quick sniff would give you, if there is more than 50% reduction in the size, that is, it is collapsible. And if in the deep inspiration you do it, or in a quiet respiration, 30% change in the diameter, we say that IVC is collapsible. So based on diameter and collapsibility, we calculate or we guess or judge the RA pressure. What is that? That if the everything is normal, that the IVC size is normal, IVC collapsible, that means the pressure in RA is 3 millimeter of mercury. Or if both are bad, it is dilated and non-collapsible, we add 15 as an RA pressure. And in case one of these is right, another is not, then the pressure is 8. Look at the huge jumps. And we presume that RA pressure cannot be more than 15. We have patients where RA pressure could be very, very large, tricuspid stenosis or severe PAH. RA pressures can be very, very high. So these were the kind of things what we had given. So now there are problems when you are trying to calculate RA pressure. The problem generally is with mechanical ventilation. The IVC is already dilated, and we add a stent to all patients, and in case it's collapsible, then we say okay, it is less. In athletes, when you have a large body surface area person, you have some obstruction by eustachian valve or something, the IVC parameters are not going to be accurate. Even otherwise, if we are thinking that is going to be accurate, let's look at this graph very carefully and minutely. Let us say this is the echocardiography estimate of RA pressure. This is the right heart catheterization. If we said the RA pressure was 5, it could be 4 or it could be more than 10 on the cath. And if we said RA pressure was 10, it could be as low as 2 or 3, and it could be as high as 15. But if we said RA pressure was 15, look at the scatter. I said on echocardiography, based on IVC dilatation and non-collapsibility, it is 15. And the RA pressure on cath was less than 5, or it was more than 20. So there is such a huge variation in RA, the pressure calculation based on catheterization and echocardiography. So that's where we understood the inaccuracy. Second part of the recipe is TR, pressure gradient. Let's go to the basics. How do we calculate TR? We do it by a modified Bernoulli equation, and original Bernoulli equation is pressure in one chamber and pressure in the other chamber depends of convective forces, flow acceleration and viscous forces. We only take into account of this convective forces, and we forget about flow accelerations and viscous frictions. So let's say, what is viscous friction? Let's say if you have a patient with anemia, the blood is thinner. If you have a patient with polycythemia, does happen in a lot of patients where we need to know PRTR pressure because of cyanosis. Now this polycythemia would increase And you have other conditions where, like multiple myeloma, where viscosity of the blood is high, and you are going to make errors, far larger errors than you otherwise would. We've kind of simplified our equation, and we said that okay, from V2 to V1, we just calculate the difference and multiply it by 4, and we further simplified, say just one velocity ahead of the stenosis, and forget about the proximal velocity because it's usually less than 1. So then equation is 4v square. So we made lot of assumptions, and we are going to pay the price for those assumptions. And now I'm going to show you the problems. So we've lost that viscous forces there. We have kinetic energy then is lost. We have not taken that into calculation. The Bernoulli equation is tuned more for turbulent flows and not for laminar flows. So in case you have a free flow TR, which is laminar flow, not a turbulent flow, you're going to be more inaccurate in these situations. And this is a free flow TR in a patient which had unguarded tricuspid orifice, and you can see immediate blunting of the TR velocity because the RA pressure increase here because of torrential backflow from the RV, and it's not like a usual TR envelope what we would see, and this indicates that it's a free flow, and this is the situation where you are likely to have more errors. Let's have a reality check. If you compare TR pressure gradient by cath and echo, and these are the differences. Now in the mild, the differences between the two could be less than 10. That is kind of acceptable. But in case of a severe and very severe TR, now look at the cath and the differences. The differences can be as huge as 20 millimeter of mercury between the cath and the regurgitation on. So in a severe or moderate TR, the correlation between these two. So now most of the guidelines, including recent European guideline 2023, which has been there for last about 2 weeks now, then they said that okay, if we are inaccurate in calculating the exact PA pressure, what should we do? Now they say we should write only the probability. You tell that is it low probability of having PH, is it high probability of having PH, or it's intermediate probability of PH. That's how actually we've been giving report for many years, and this is all of you should follow. Please do not mention PA pressure is equivalent to 4V square plus the RA pressure, right? So we can only say probabilities. Low probability, intermediate probability, or high probability. Now let us see how it is. If the velocity is more than 3.4, okay, it is high probability. You don't need any other data. And if it is less than 2.8 and there is no echo parameter saying that this could be increased in PA pressure, echo parameters, I'm going to show you what are the echo parameters of indicative of PAH. If there is no echo parameter, then it's a low. Now in case the echo parameters, more than 2 echo parameters are there, it falls in the category of intermediate. So intermediate probability. Now remember this slide, and that's very important. And what are the parameters? The echo parameters: RA dilatation on parasternal long axis view, RV dilatation on the apical 4-chamber view where it is more than 1 or bigger than LV, and then a flattening of on a cross-section view of interventricular septum. RV pressure is more, the LV rather than circular flattens either in systole or diastole. IVC is dilated. You have the acceleration of less than 100 meter per second, millisecond. If you have acceleration time which is less, it indicates PAH. And there are so many other parameters which can actually make you decide that this there are 2 echo parameters which are consistent with the pulmonary artery hypertension. If there are 2 parameters, then it becomes intermediate category, or in the intermediate category, if there are 2 parameters which are present, it jumps the category from intermediate to high category. So we can only say probabilities, not the PA pressure, because we are more than 50% likely that we would be wrong. I hope I was able to elaborate the point and got you to an area where these are the recent guidelines which recommend that you should not use PA pressures, you should use the probabilities of having a person PAH. Do subscribe to the channel, because we all would learn together and you would be notified as and when I publish any new video or data on YouTube. Thank you very much for watching it.